So today I'm going to be having a generalized complex seizure. And as you can see, it's going to be tonic and clonic at the same time. And you can tell because of the stiffening of the muscles and the rhythmic convulsions. And the immediate life-threatening effects of the seizure are obstruction of the airways and injury to the head.
Hi, I'm the physician during this patient's seizure. I'm going to teach you the ABCs and the things to look for. ABCs are, you got to make sure he's breathing. He's breathing. Make sure there's nothing around him where he can hurt himself. Probably take those things away. And make sure you don't hinder his movements in any way or put any things in his mouth. Next things I have to look for are any secondary causes, like if he has trauma or an infection, any ADRs, anything along those lines. He looks good. So I'm going to call my pharmacy team now to talk to you about drugs and what to give them.
Hi. My name is Sarah. I'm a pharmacist here. One option you have for this patient is phenobarbital. It can be used for status epilepticus. If given in the IV form, you can give 15 to 18 milligrams per kilogram initially. Phenobarbital contains a phenyl ring, which is a property that allows it to act as an anticonvulsant over other barbiturates. It is absorbed 100% and is 25 to 40% protein bound, but it's distributed throughout the whole body. So therefore it is non-selective. This is why phenobarbital has so many adverse effects and should not be your first choice. They also have a lower therapeutic index than benzodiazepines, so they can be more toxic. Its mechanism of action is to bind onto the allosteric site of GABA-A receptors and potentiates the effects of GABA. It will increase the length that the chloride channels are open. It may also inhibit glutamate. This will allow the neuron to become hyperpolarized and prevent excitation, therefore inhibiting the seizure.
Wow. Thank you. It sounds more like a prophylaxis drug, but I'm going to have to think about a different drug in this case.
All right.
Thank you.
Hi.
Hi.
I'm Caitlin, a pharmacist here. I'm here to recommend lorazepam, which is a benzodiazepine. According to a few sources, lorazepam is one of the first choices for status epilepticus. For patients 18 years and older, the recommended dose is 4 milligrams IV given slowly at a rate of 2 milligrams per minute. If seizures continue or reoccur, the dose may be repeated after 10 to 15 minutes. You may also give it intramuscularly. It is absorbed immediately. Lorazepam is 100% available when given intravenously and 83 to 100% if given intramuscularly. It is 85 to 91% protein bound and has a volume of distribution of 1.3 liters per kilogram. Also, in some studies, lorazepam raised cerebrospinal fluid levels up to 28%. Lorazepam, like all benzodiazepines, binds to GABA-A receptors and potentiates GABA effects. Thus, it will hyperpolarize the cells, causing the patient to stop seizing. Lorazepam is a good choice for status epilepticus.
That sounds like a great choice, but unfortunately he's allergic to benzos, so let's go with something else.
Well, glad to help.
Thank you.
Hi, I'm Courtney, another pharmacist here. I recommend fosphenytoin for status epilepticus. Fosphenytoin is a diphosphate ester salt of phenytoin, which acts as a water-soluble prodrug of phenytoin. After administration, plasma esterases convert fosphenytoin to the active drug phenytoin, which decreases seizure activity by increasing efflux or decreasing influx of sodium ions. For status epilepticus, use fosphenytoin IV. The loading dose is 15 to 20 milligram phenytoin sodium equivalents per kilogram, administered at 100 to 150 phenytoin equivalents per minute. Absorption is immediate and protein binding is 95 to 99%. The volume of distribution increases with dose and rate ranging from 4.3 to 10.8 liters.
Thank you. I think I'm going to be using that drug. It's been about 9 minutes now. At the 10-minute mark, I'm going to inject him with fosphenytoin.
Okay.
Thank you.
Hi, Mr. Yang. My name is Mike. I'm a pharmacist here as well. Today we'll be performing a discharge consultation. And I see here in your chart that you're recovering from an epileptic seizure. That's good news. And it shows that they used fosphenytoin to resolve the seizure. Well, today we'll be discharging you with a different medication that's designed to prevent such unfortunate events in the future. We're sending you home on valproate. Like fosphenytoin, this medication can be used for events similar to the one you experienced, but it is far down the list of preferable options. However, for preventing seizure events, valproate is one of the best medications. It works by increasing the concentration of the inhibitory neurotransmitter GABA in your brain by preventing its metabolism or reuptake. They're not quite sure. But additionally, it also inhibits voltage-gated sodium channels, culminating in an overall decrease in neuronal hyperactivity. Your valproate will come as an oral tablet, but don't worry, it is 100% absorbed this way, reaching its maximum concentration within 1 to 4 hours. The actual plasma concentration varies widely from patient to patient, so we'll monitor you and make sure that you're receiving the therapeutic dose. And while valproate is about 90% protein bound, it still distributes through to your cerebral spinal fluid and even saliva. What questions do you have for me?
None.
That's all, folks.